Thank you very much, Mark, for your kind introduction. So this talk will be about some recommendation in image acquisition and interpretation in patients with heavy coronary artery calcification and implanted stents. So I thought I would divide the talk in four main points. First, what is it that we are trying to do? What is the clinical question we are trying to answer? And what is the problem we encounter there, if there is any? Then the core of the talk is about the tips and tricks. So what technical recommendation can be followed in terms of selecting patients, preparing them before the scan, choosing the appropriate scan protocol, and post-processing our images. And I thought I would wrap up with some clinical recommendation and examples. So the clinical question we are trying to answer in patients who undergo coronary CTA and are found to have some calcium in the coronary arteries. Calcium, as you all know, is a quite sensitive sign of atherosclerosis going on in the coronary arteries, but it's not a specific sign of having severe coronary artery stenosis at that level. Calcification is not invariably associated with severe stenosis. And I thought I would show you data from a very well-known paper published a few years back in 2008, data which have been confirmed by many other papers which have appeared more recently. This is an analysis of the degree of calcification at the segment level, so in each coronary artery segment, judged visually as none, moderate calcification, or high calcification, which just means bulky. A lot of calcium which occupies more than 50% of the lumen of the vessel, so that you can't actually see the lumen of the vessel very well. Whereas moderate calcification means it just impacts less than 50% of the vessel lumen, so that you can assess the rest of the vessel. So first, the prevalence of significant stenosis was 5% with no calcium, 17% with moderate calcification, and 25% with very bulky segmental calcification. Okay, so 1 in 4. And in these scenarios, whereas we can be pretty good in identifying the 1 in 4 segments which harbor significant stenosis, we are not that great in identifying the 3 in 4, 3/4 of the segments which do not harbor significant stenosis. Our ability to do that is approximately as good as flipping a coin. In coronary artery stent, we are looking for something different. We are looking for a degree of in-stent restenosis. In-stent restenosis is the excessive healing response to the injury caused by the balloon, a process which is paraphysiological and we call neo-intimal hyperplasia. And when that is too much, we call it in-stent restenosis, which affects at least 50% of the in-stent diameter. When it is at least moderate, at least occupying 50% of the in-stent diameter, then it can be the cause of recurrent patient's chest pain. However, we have to bear in mind that since the introduction of bare metal stents in 2003, the prevalence of in-stent restenosis, the introduction of drug-eluting stent, I meant to say, in 2003. So the prevalence of in-stent restenosis in drug-eluting stent is less than 10%. So if the patient has received a drug-eluting stent, this is an entity which can occur but is not very common. So we would like to be able to rule it out, hopefully by using a non-invasive test. What about the diagnostic performance of coronary CTA in patients with stents? This is a meta-analysis published a few years back of 14 studies showing that overall the pool sensitivity and the pool specificity of coronary CTA compared to invasive angiography is pretty good. Sensitivity is in the order of 90% and specificity in the order, again, over 90%. However, if we look at the percentage of the amount of stents which were actually accessible based on the stent diameter, we see that we have high percentages of available stents when the diameter is at least as large as 3 millimeters, and variable percentages of available stents when the diameter is less than 3 millimeters, with studies reporting values as low as 8% as the percentage of stents, small stents, which are available. So what is the problem in stent imaging in addition to stent diameter? Another factor is the material the stent is made of. Look at this example of a stent which is very, very dense, and basically because of the artifact related to that, it does not allow us to evaluate the in-stent lumen. I put in by comparison a stainless steel stent whose struts are much less dense on the CT image, and also a non-opaque bioabsorbable stent which does not have opaque struts but just radio-opaque markers at its edges, although these ones are not widely used in clinical practice yet. Other factors that can affect the availability of a stent is the configuration. So very aggressive or imaginative, if you want, interventional cardiologists could be using techniques such as crush stenting or culotte stenting or stent-in-stent, V-stenting, where there is an overlap of stent struts, so multiple layers of metal will be found at the level of a specific lesion or part of a lesion, so that the entity of the artifact we will find, and which are related to the presence of metal, will be even worse. So for this long list of reasons, starting with the stent diameter perhaps as the most important reason, the appropriateness criteria document published in 2006, which was describing the appropriate use of cardiac CT in a range of clinical scenarios, wasn't really recommending the use of cardiac CT. Actually, the use was discouraged because it was deemed to be uncertain in patients with symptoms and definitely inappropriate in patients without symptoms. So what is the problem here? When we are trying to do this, what is the problem we encounter when we image patients and these have bulky calcifications in the coronary arteries, or these patients have previously implanted stents? This is something we normally call as clinicians the blooming effect, which describes the visual impression we have when we look at images which contain calcium or stents. These structures typically look, at our eyes, bigger than they actually are. So the principle of this is that a mix of artifacts, which are well known in digital cross-sectional imaging, play a role here. One being partial volume averaging. For instance, we have voxels of the size of 0.4 times 0.4 times 0.4 millimeters, which are relatively large compared to the size of the objects as we are trying to image. And I've just rounded up the size of the stent struts as 0.1, although these can be even smaller than that. So there is a problem clearly related to spatial resolutions. So as a result of that, tissues of very different density will be included in the same voxel, and the attenuation assigned to that voxel will be the average of the attenuation of the different tissues. Now, a way of improving spatial resolution without decreasing exceedingly the size of the individual detector element is that of using an improved, a more efficient detector. And this is a diagram that I got from Siemens that shows that the stellar detector, the newer detector, has an improved geometry from an engineering point of view, so that the parts are much closer to each other, so that the images which are produced are much more free from noise. So as a result of that, you can not only decrease perhaps the radiation load that the patient receives, but importantly, you can obtain thinner slices. So that's practically a way of improving your spatial resolution. Now, preliminary results with this type of detectors, improved detectors, show that there is a better estimation of the in-stent lumen diameter compared to intravascular ultrasound, which is an invasive catheter-based imaging tool to measure some vessel characteristics by using high-definition latest generation detectors as compared to conventional 64-slice CT detectors. Temporal resolution plays a role in this because it's still a very important factor which affects the image quality. And motion artifacts blur the stent struts. This is something we can experience every day. They blur a bulky calcification in the vessel wall. They will blur the stent struts. So high temporal resolution and heart rate control remain factors which are very important. This is a study that looked at the phantom, and by imaging the phantom, simulate different simulated heart rates, they found a much better image quality when the heart rate was lower, which is not entirely surprising. Regarding the choice of the kilovoltage, we have to bear in mind that structures with a high atomic number, such as hard bone, for instance, and calcification, dense calcification behaves a bit like hard bone, have a quite typical pattern of X-ray attenuation, which you see shown here, indicated by the red curve. So hard bone has a lower attenuation, X-ray attenuation, when you increase the energy of the photons. So clearly, in order to minimize that halo that we see around a dense calcification, for instance, that we called the blooming effect, we could simply increase the energy of the X-ray photons we are using, hence increase the kilovoltage. Although in principle we don't want to do that to minimize radiation dose to patient, but it may be necessary to do it. This is a study done again in a phantom showing that the amount of poor image quality cases they had was lower when they imaged patients at an increased kilovoltage. They also compared to different protocols, a prospectively ECG-triggered protocol and a retrospectively ECG-gated protocol, and perhaps related to the absence of interpolation when using a prospective CT ECG-triggered protocol, they found a slightly better image quality in the scenario of a prospectively ECG-triggered protocol. The contrast injection protocol, I believe, in clinical practice plays a role when you are trying to image a patient with an implanted stent, or once you found there is a bulky calcification, one or more bulky calcification somewhere, and you still want to do your coronary CTA. So I think we should express this, the quality we want to achieve in terms of iodine delivery rate, or IDR, which is really a measure of the good coronary attenuation we want. As a rule of thumb, you have to bear in mind a target of 2 grams of iodine per second as iodine delivery rate. So that can be achieved if you use a high concentration contrast agent with a concentration of 400 milligrams of iodine per mil. That equals to injecting that at 5 mils per second, and you will have an iodine delivery rate of 2 grams per second. If you're using a different type, different concentration for your contrast agent, then you can still achieve the same target iodine delivery rate by adjusting your injection rate, because you just multiply your injection rate times the concentration of the contrast agent. And what you can see here is the effect of changing the contrast agent concentration and the kilovoltages on the attenuation that you can achieve. This is a phantom study done with equal dilution of 1 part of contrast and 30 parts of saline solution, imaged. Clearly the different types of contrast will be used, so the concentration of contrast agent, as a matter of fact, will be increasing in this direction, going from top to the bottom, and these were the different kilovoltages that were used. And not very surprisingly, having a higher concentration of contrast will allow you to achieve a more constantly higher attenuation. Remember, that's your target. You want to give at least 2 grams of iodine per second, and you would like to achieve at least a 250 ounce per unit for the intravascular attenuation. I think we need to spend a word on post-processing. This is quite important. So when you have acquired your scan and you're about to reconstruct your pictures, let's imagine you have a patient with a stent implanted, or let's imagine you have some calcification in your vessel wall. So you can reconstruct the dataset with your conventional cardiac CT convolution filter that in Siemens is called B26F, and you obtain that picture. Okay? This is a phantom imaged in vitro, so no motion here. However, the visualization of the lumen in that picture is not great. You can see that there is still some degree of halo around the stent struts. We call it blooming effect. And by reconstructing the exact same dataset with a dedicated sharp convolution kernel, which is called B46F, we see that there is a better depiction of the instant lumen. This is really clearly visible by naked eye. So this is an example in a real patient. This is the same dataset that I just reconstructed 6 times. The top row is reconstructed with a conventional convolution filter for cardiac CT, and the bottom row is reconstructed with the dedicated the sharp convolution filter for cardiac. There is another aspect here that I want to emphasize, and this is really important. When you look at your picture, when you evaluate your scans visually, it's quite important that you adjust the window settings in a way that you can minimize the blooming effect, quite importantly. So, for instance, the standard window settings with a center at 150 and a width of 500 is not ideal for the visualization of the instant lumen. And just by widening that, for instance, in the 2 images highlighted in yellow, you can obtain a much better visualization of the instant lumen. And probably these 2 pictures with the wider window settings represent the best compromise. Clearly, application of a dedicated sharp convolution kernel has a sort of side effect, which is partially undesirable, which is that of increasing the image noise a little bit. So there is another tool available, which has been available for the last 3 or 4 years, which is iterative reconstruction, which is available for scanning different parts of the body, and it can also allow us to diminish the tube current to some extent, minimizing radiation exposure to patient. But in this use, I think the really important value is perhaps that of reducing image noise, especially when we have added some image noise by selecting a dedicated sharp convolution kernel. And again, you see here a combination of filtered bud projection, the two images are on the left, and images reconstructed with a maximum degree of iterative reconstruction on the scanner. And you see that the combination of a dedicated convolution kernel, this is the equivalent kernel for iterative reconstruction, and iterative reconstruction achieves the best compromise between visualization of the instant lumen. I believe this is better than that, and this is better than that, but also a relative improvement in image noise. Finally, regarding protocol, I want to mention dual energy and the possibility to perform a monoenergetic or spectral decomposition of the energies. So what you see here is the stent in vitro. You've seen it previously in the talk. We have scanned it with dual energy protocol, and we then reconstructed images by selecting data coming from different energy levels. So you'll have a monoenergetic image at 70 kiloelectron volt, monoenergetic image at 100, monoenergetic image at 120 and 140. As expected, based on what we described earlier regarding the attenuation changes of hard bone and metal, we have that the image at 70 kiloelectron volt has some degree of blooming effect in it, which is visible by eye, whereas the images obtained at 120 or 140 is virtually free. We can hardly distinguish the stent strut in these pictures. So that's potentially helpful if we want to minimize that false impression of the stent being bigger and preventing us from evaluating the instant lumen. Clearly, by doing so, because we are selecting part of the information which is available, we are introducing some noise in the pictures. And again, combination of monoenergetic decomposition and iterative reconstruction can improve image quality. Having said all that, with dual energy, there are always some caveats. We have to bear in mind what happens to temporal resolution when we are using multi-energy level from a dual energy scan. Is it the same as using monoenergetic scanning in the first place? That's not always the case. To date, I believe the ability to distinguish the metal from contrast based on energy absorption characteristics by the analysis of spectra and in patient remains pretty unclear. So I'm not aware that these applications have proven robust clinical utility at the moment. I want, however, to say something about the clinical utility. So this is a study which dates a few years back, and this was a study done in 70 patients who had undergone 64 slides, coronary CTA, and conventional angiography in patients who had an unprotected stent in the left main stem. Cardiologists tend to be very cautious with these patients, even if they are asymptomatic, because clearly any problem and degrees of in-stent stenosis or even neointimal hyperplasia in the left main stent may be the cause of sudden death. So there is a cautious approach and surveillance in this patient. So the left main stent represents a good scenario for CT because we are talking about a large vessel, hence receiving a relatively large stent and relatively protected from motion artifacts. So this study was definitely positive and encouraging in terms of results because the sensitivity was excellent. We could evaluate all the patients which actually had in-stent stenosis as demonstrated on invasive coronary angiography, and also the specificity was really encouraging. This chart gives you the thickness of the neointimal hyperplasia measured not with CT but with intravascular ultrasound as a measure of the degree of agreement between CT and intravascular ultrasound. And if you accept, for instance, that 80% of agreement is a good agreement, something you're happy with as a comparison between CT and intravascular ultrasound, I think that's exceedingly good. It's really good. That means that CT could detect 1 millimeter thick foci of neointimal hyperplasia, which is a good result, very robust results. So The appropriateness criteria for cardiac CT were revised. I showed you earlier what people thought it was a good idea to do in 2006, and in 2010 things look a little better for CT, because it's now thought that although it still remains uncertain on an appropriate diagnostic tool in patients with symptoms or ischemic equivalents, in asymptomatic patients who have either unprotected left main stenting or a large stent somewhere in the coronary tree, this tool is deemed to be appropriate. I haven't found any consensus documents which are later than 2010 for what concerns specifically cardiac CT, but just earlier this year there is a document on the appropriate multimodality assessment of ischemic heart disease. So this wants to be multimodality, not only cardiac CT. And whereas basically it is thought that, you see, in symptomatic patients or patients with ischemic equivalents, functional modalities such as stress radionuclide imaging or stress echocardiography, stress EMR, or invasive coronary angiography are deemed appropriate, CT angiography and stress ECG are not probably first line, according to this document. Whereas in patients without symptoms and unprotected left main stenting, all modalities may be appropriate, which includes coronary CTA. It is deemed in this document that other stents in asymptomatic patients probably do not require, in the majority of cases, any follow-up. Okay, so a quick checklist, practical checklist for interpretation. I think these are some points I haven't mentioned earlier. So remember, when you see a distal runoff, distal to a stent, you see a patent vessel. The patent distal runoff can be supplied by collaterals, so it does not imply necessarily that the stent is fully patent. Remember that stent edges, 5 millimeters proximal and distal to the stent, undergo the injury of the ballooning, but that they are not covered by the stent. So these are good sites, possible sites where intimal hyperplasia can happen. Okay, we need to describe them. Actually, we need to describe the entire treated vessels and remember to locate findings and the relationship with side branches, which makes the comparison of the findings, especially with other tests that the patients may have had previously, very, very important. And otherwise, what we write in our report, it becomes difficult and impenetrable to the cardiologists. And finally, don't disregard remote disease, because that may be the cause of patient symptoms, and it may be anyway very relevant in defining the options for treatment for that patient. Importantly, in patients with very diffuse disease, with a reshaped coronary anatomy, the significance of the CTA findings can be very unclear in terms of hemodynamic value. We can't predict it most of the times. So it has to be seen whether new tools such as perfusion imaging, that can nowadays be done with CT, but clearly we can get the information on perfusion from other imaging modality, is definitely a very important piece of information in these patients, for guiding management. So I go to my conclusions. First point, we define the clinical questions we wanted to answer here. For vessels with bulky calcification, we just want to know whether the calcification is associated with a stenosis. And for stent, in a patient with symptoms or in patients without symptoms, we want to see whether there is any degree of in-century stenosis. The problem here when we approach this type of patients is that we might have on our images the impression that these structures are bigger than they actually are. They prevent us from seeing the vessel lumen very well. We call that the blooming effect. And we have to try and minimize it, which we can do to some extent by choosing the appropriate CAM protocol, making sure that the patient is prepared, heart rate control as much as we can, appropriate contrast injection protocol, and good post-processing. Remember the appropriate convolution filter and the appropriate window settings as well. Clearly, the indication of the scan, in light of the appropriateness criteria I've shown you, makes us choose as to whether this diagnostic tool is safe and sound in a specific clinical context. Okay, so it's all. Thank you.